Allora, ho preparato non una relazione ma una traccia di una relazione, perché il punto della mia tavola rotonda adesso è prettamente chirurgico. Ci ritroviamo spesso a operare pazienti per svariate cause, diabetici e non diabetici, e a ritrovarci nell'immediato post-chirurgico con un sanguinamento. Non sempre è facile decidere che cosa fare, reintervenire subito, aspettare, quanto aspettare, e quindi la chiave di questa tavola rotonda è cercare di arrivare ad un consenso su come comportarci nelle diverse situazioni. Parlerò un po' in inglese, un po' in italiano, come viene, per cercare di capirci un po' tutti. So the point that we want to clarify, to reach in this roundtable, is to try to understand when to intervene if we have a postoperative bleeding and when to wait. There are a series of open questions. How long to wait before re-entering the eye? Can we base our decision on the B scan and just look at the possible presence of a retinal detachment, then intervene only if the retina is detached? However, if we have used air or gas, it's not easy to make an ultrasound. We cannot have reliable data. Se abbiamo aria o tamponante gassoso non riusciamo a avere informazioni dall'ecografia e quindi non possiamo neanche vedere con attendibilità se c'è un distacco di retina o no. Ci basiamo sulla pressione alta o bassa, ci basiamo sulla presenza di sangue nella camera anteriore o sulla patologia primaria, cioè se era un distacco in origine o un diabetico grave ce ne preoccupiamo di più rispetto al fatto che fosse una membrana epiretinica. So, which criteria do we use to decide whether to re-intervene immediately or not? Based on the presence of retinal detachment, on the IOP, low or high, on the presence of blood in the anterior chamber, and or on the primary pathology, diabetics versus not, or what is the vision in the other eye, if the patient is totally blind or not. So let's write down together some guidelines. So let's say that we have a postoperative bleeding and we can determine that there is a retinal detachment. In that case, do you all agree to intervene immediately? Do you have the microphones? Yeah. Sengul, would you go back to surgery immediately if you just suspect to have blood and a retinal detachment?
If there is retinal detachment...
Turn on.
I think it works now. If there is retinal detachment, yes, I would definitely intervene with the case. But if there's no retinal detachment, it depends on many things.
Okay,
Should
so
I
let's
discuss later?
Wait.
Okay.
So, for a retinal detachment, probably we all agree. Is there somebody of you that would not go back for some reason? Ok. Cioè, se abbiamo un distacco di retina ed è abbastanza certo, almeno il sospetto, è giusto tornare in chirurgia subito. So let's say that we don't have a retinal detachment or we don't think so, but we have a postoperative bleeding and high IOP. So what's your management? You just try to use medical treatment of the IOP, or do you think it's better to go ahead to surgery and do surgery immediately? Silvia?
My experience is that if you only do an interior chamber irrigation, which is quite frequently done, that doesn't help too much because the blood again comes to the zonules in the interior chamber, and thus if you are forced, as no other treatment medically is successful, to re-intervene.
Quindi è meglio reintervenire, dice, e non semplicemente lavare la camera anteriore perché comunque presumibilmente nuovo sangue verrebbe davanti. Thanasis.
Because the problem is from the blood. And
The blood itself. Okay.
Itself. So you have to remove, like in medicine we always do, have to remove the causative problem, which I have
only if there is also in the anterior chamber? Or
No. It doesn't matter where the blood is. It matters that the intraocular pressure is high, and you're in danger of having problems from the eye because of the pressure. You're not controlling the patient 24 hours a day. So the
Okay.
patient can be outside your control. So in order to be safe for the patient, for yourself, you need to intervene immediately. I
Because-
think the sooner the better. Because if you remove the cause,
that medical treatment is enough.
no, I don't think medical treatment is enough because it doesn't apply to vision. You need to restore vision in most of the people. People are coming to you because of restoration of vision. So if you already have vitrectomy and you have blood, then to wash out the blood is not a difficult case to do just a washout.
Well, I agree, but you have to put back the trocar, you have to go back to surgery. Don't you think that if you wait 1 week, maybe you can see whether the blood will go away by itself?
No, with intraocular pressure, because you cannot control intraocular pressure
Okay.
24 hours a day yourself.
Okay, Silvia.
But it depends on the height. If you have a healthy eye and you have maybe 2-3 weeks an intraocular pressure of 40, so that doesn't matter so much. But if you have an IOP of 60, then time matters much more.
What's the safe threshold of IOP for you?
For me, if
In a healthy,
in the
non-glaucomatous eye?
in the healthy eye, I would accept 35-40 for a certain time. Yes.
Roger. Quindi sì, la dottoressa Bob accetterebbe 35-40 mm di mercurio per 3 settimane in un occhio non glaucomatoso. Roger, what would you do?
I think you kind of break people down into maybe the aggressive surgical people, perhaps, and a little bit more conservative. Maybe there's a gray line here, but I slightly disagree with my Greek colleague here by saying that blood has to be evacuated, and you can't really monitor throughout the day. You can give medical treatment, like you said, Barbara, and then just see how it goes, because they can work in 1-2 hours and see how they behave. Yes, if it doesn't react to it, you can see them the next day, for example. If it doesn't actually clear off, obviously you have to clear it out. But yeah, absolutely, conservative management first, medical treatment, and then see what happens. And you also need to know what the cause is. So they have a choroidal hemorrhage underneath, and perhaps they're on warfarin.
Sometimes
There's a lot
it's
of
not
factors.
easy to know the cause. It can
Yeah.
be from the sclerotomy, it can be because it's diabetic and you have the neovessels. So we will see based on diagnosis. Lyndon, what is your behavior?
I would treat medically and watch.
You would treat
Medically
medically.
and watch, and I'd be uncomfortable with the patient of 40 for weeks, even if they're healthy, but I would tolerate
Maybe 1 week,
up to 30
okay.
and be watching them very closely. But 40 for 3 weeks for me would be uncomfortable.
And Roger and Lyndon, would you recommend a specific therapy or just any therapy to lower the IOP? What would be your choice? Let's say we are talking about early postoperative, so maybe you don't want to use prostaglandin, you want to use beta blockers, something orally, or what would be your choice? Just try?
We usually try and get the pressure very well controlled in the clinic, so we always give a single dose of oral Diamox.
A single dose of Diamox.
Just because the ones that in the clinic don't move from 45 with Diamox in the clinic, this is a difficult case.
Okay.
But if you can drop it...
So you judge based on the answer to Diamox whether it is
and
difficult or not?
Drops, yes, because I'm very concerned if someone stays in the clinic, gets 500 milligrams of Diamox, has iopidine and other drops, and the pressure still stays in the mid to high 40s. This is worrying as well.
Okay. Is any of you accepting the idea of making a paracentesis and just drain some blood to keep the IOP safe, or it doesn't make any sense because in a few hours the blood will be still there and you just keep having your problem?
May I respond to my British colleague here?
Yes. There is still
aggressiveness.
British versus non-British.
No. We still want to exit, but the British don't let us. The thing is, in cases like that, aggressiveness, it's part of the method. In the old days, to do a vitrectomy, it was a great trouble to go back. Now, with 27 that I'm using almost 80% of my case, it's like injecting with Avast in the eye.
Okay.
I mean, it's a small injection. You don't think of vitrectomy as a huge vitrectomy problem.
Yeah,
So
okay.
to go back and solve the problem
It's
with
not
injecting
easy.
the 27 gauge, I don't think it's so much trouble waiting for the patient.
Sì.
And you cannot see the patient at night if he has 60 or 40.
And you feel better to know what's going on.
Of course.
This is a different approach, è un approccio diverso, cioè avete capito, il dottor Nikolakopoulos dice dal momento che la vitrectomia è sempre meno invasiva nella tecnica, mi sento meglio andare dentro, lavare, vedere che cosa c'è e gestire il problema immediatamente, mentre ci si può confrontare con un atteggiamento più attendista che prima aspetta, guardiamo, abbassiamo la pressione, vediamo se risponde nell'arco di una settimana e poi decidiamo che cosa fare. Silvia, sorry.
I would behave differently if the patient is the diabetic or
Okay,
not.
so let's get to diagnosis, based on diagnosis.
Okay, yeah, okay, just a
Go ahead.
little. If I feel that it's because of sclerotomy or something, nothing from the vascular, retinal vascular problem, then I would prefer to wait instead of intervening. But
Okay.
if I think that it's a vascular problem, it's already ischemic retina and
That has to
also
go
some neovascularization at the back, and those eyes are not so resistant to IOP problems also, and also it may continue. I mean, the bleeding may continue, so I would prefer to
go
do
back.
yeah.
In fact, let's move on to the next step. What if the patient, maybe it can't happen, but it could happen? What if we have hypotonia? That could be maybe a bleeding sclerosis. Well, I don't know if it would last, because if it keeps bleeding, the pressure likely would go up. But we could have a bleeding sclerotomy and hypotony, and then,
Just the next day,
yeah, the next day.
if we feel severe hypotonia, I wouldn't hesitate to put some
To put
air,
some suture.
or if I believe that it's because of the still leaking sclerotomy, I would put suture, of course. But if it's a 25 or 27 gauge vitrectomy, you can just put air into the vitreous so that it will seal the leaking point probably.
Silvia?
I wouldn't hesitate to do that.
I think if you've got a bleeding eye or an eye that's bled with hypotony, you already have a reason why it's bled. It's because of the hypotony, more than likely. And you have to treat, that's where you need to treat the cause. It'll probably continue to
Quindi il
bleed.
punto è, poiché c'è ipotonia, sicuramente c'è qualcosa che la causa e quindi bisogna andare in quel caso sì a cercarla e capire perché.
And then to put air in, put gas in, I presume that would be slightly blind in a bleeding eye or an eye with hemorrhage, a little bit precarious perhaps, that you can't see it. Perhaps in that case you can actually clear the blood, suture the ports and put another tamponade in, for example.
Well, in that case, it could be dangerous or risky to go back to trocars because we could have a choroidal detachment and maybe we are not sure and we can't really trust the ultrasound. So an injection with the needle behind the lens, but maybe we can't see it. So it's not easy because it depends on whether we have anterior chamber blood or not. So what would you do? Would you wash the anterior chamber and try to inject a bubble of air in the posterior? No. What would you do?
So this situation usually occurs after, let's say, a simple vitrectomy for macular case.
Right.
If you have ruled out that the sclerotomy site, irrespective of what technique you use, are closed, and so for me there is no reason to do something immediately. Vitrectomy itself has an intrinsic risk that hypotony occurs, and most often in myopic eyes, because the scleral shell obviously is weaker and there is something happening that the ciliary body reacts curiously. So I usually rule out that there's no massive choroidal reaction, and they just put them on hourly steroid drops, and it will resolve within a few days.
Okay.
So it's important to rule out the cause of a hypo. Usually it's after vitrectomy, maybe they have cuffed or the blood
Okay.
pressure has been
So
high.
you tend to wait
So
one
I
or
tend
2
to
days.
wait, yes.
Okay. Well, let's say we have bleeding and we have silicone oil behind. So Which eyes are this? It could be a diabetic tractional detachment with some breaks. It could be a PVR case. It's a more difficult situation as far as the retina condition. Usually, if there is silicone oil, we don't have massive vitreous hemorrhage. We have localized vitreous hemorrhage behind the silicone or mixed into it. So how would you do? What would you do in that case? Let's say that you have a massive hemorrhage at the posterior pole, you can't see behind, and you have silicone oil inside. Do you think you can wait for reabsorption and then see?
Yeah. You should go wait a certain time, because at that moment it's clotted, and removal from the retina can be a really tough thing, and there's a high risk of rebleeding, because usually it comes from vessels you have been peeled and they are relatively fresh. They have to establish a vessel wall. What happens then when it gets resolved? Then it goes around the bubble, and then maybe after 2 weeks you have the problem in the anterior chamber with high intraocular pressure and so on. And I wait usually when I can see that there is a lysis of the blood, and when a movement into the anterior chamber occurs, then I go for repeat surgery.
Bene, quindi lei dice nel momento in cui c'è silicone possiamo permetterci di aspettare di più, perché verosimilmente c'è una chiazza di sangue dietro la bolla di silicone davanti alla retina, che è un coagulo. Poi il coagulo si scioglie per la fibrinolisi naturale e quindi un po' di sangue potrebbe passare davanti, nel qual caso comincia a essere un problema maggiore, perché la pressione verosimilmente aumenta e non si vede più. Mario, hai da aggiungere qualcosa?
Se però c'è un underfilling,
c'è
underfilling,
c'è un
sottoriempimento, anche in posizione ortostatica il sangue
va sotto,
può risalire a livello maculare, perché l'olio va su, e quindi il contatto in aria nella zona maculare del clot che si forma non è il massimo. Se invece è localizzato solo nella zona inferiore può essere più o meno gestibile, dipende da quanto il riempimento è adeguato.
Mm-hmm. Qua direi che ci combiniamo con la causa. In realtà mi fermo un attimo sulla presenza di sangue nella camera anteriore. If there is blood in the anterior chamber, then we have also to deal with the contact between blood and cornea. In that case, how much are you concerned? For how long would you wait before being really afraid of toxicity or hematocornea consequences? Lyndon.
It matches the amount, the case you've done, and the pressure. And with these, in virtually all these cases, we're conservative, so we watch the oil with blood, we watch the hypotony, we watch most things. It's just the frequency with which you can do that. And the cases are so varied that it's very hard to say one thing. But the bad combination, of course, is high pressure, a full AC of blood, and evidence that you're starting to get corneal staining. I'm not so worried about the toxicity. I'm worried about the impregnation of blood into the cornea. This is hard to deal with. So once you start to see the pressure go up and the blood not clearing and any evidence of corneal staining, this is the trigger.
Well, anyhow, for blood to go into the cornea takes a while. So basically your management is waiting first and then go back to surgery if you see that maybe after a couple of weeks it doesn't change. Based on the pressure and...
Yeah, based on the pressure, whatever evidence you have of the posterior segment, whether the operation originally went well and you were expecting this.
So it's usually a combination of all these variables that I'm listing here.
It's really very difficult to say just one sentence for such cases. It depends on many things, the age of the patient, the intraocular pressure, the height of the hyphema, I mean just a small one or a total hyphema. All of them affects your behavior, but we have to follow the patient very, very closely, every day at least, I can say, because I have a case who was a young lady with hyphema, with diabetic eye, but with hyphema. It was a recurrent hyphema, and we just waited. I had to go for a meeting, so I left her to another colleague, and she was followed very closely. But although the pressure was something like 20 or so, just within 1 week, the cornea was totally affected.
Oh, so 1 week, una settimana
within
per
just
avere il
1
sangue
week.
dentro la cornea. Okay.
Yeah.
Okay.
So we have to be careful that there are cases
Quindi sono
like that.
pazienti che vanno seguiti giorno per giorno. Vi faccio solo vedere 2 casi a proposito di sangue in camera anteriore. Questo è un semplice caso di una collega che aveva fatto una peeling di una membrana, è alla fine, vedete, alla chiusura. E cosa succede? Succede che al momento della rimozione del trocar dall'altra parte, adesso vedete, comincia a esserci un bleeding, un sanguinamento che viene in camera anteriore. Vedete che ha il cristallino suo, non è pseudofachica, ed è quindi di curiosa interpretazione. C'è un sanguinamento eccessivo rispetto alla situazione. Sembra chiaro che venga dalla sclerotomia, ma comunque passa in camera anteriore e continua. C'è aria dietro, come vedete, non è di facile interpretazione finché la camera anteriore si riempie immediatamente. Allora anche in questo caso il chirurgo può decidere cosa faccio: torno dentro e rilavo subito, quindi vuol dire che devo togliere l'aria, devo rifare le cose, oppure aspetto che passi. It's interesting to see what you would do in a case like this, and there is a similar case in which this is another colleague, see, David Martins. These are videos from the last year EVRS. Anche questo è alla fine della vitrectomia, torno indietro, mette il gas e poi cosa succede? Chiude, e anche a lui succede la stessa cosa. Vedete che chiudendo comincia a esserci sangue che aumenta finché riempie la camera anteriore. Lui però, a differenza della collega che ha aspettato, lui cosa fa? Rientra subito, lui non vuole aspettare, vuole andare a vedere che cosa sta succedendo, e quindi sceglie di pulire e rifare un po' tutto e trattare il problema. Allora, in letteratura ero andata a vedere a suo tempo se c'era descritto qualche cosa, e c'è un unico caso, perché evidentemente è un problema che può succedere. C'è quest'unico caso di di chirurghi indiani, e che poi spiegano, si sono dati come spiegazione che il sangue venga dalla sclerotomia e che possa passare davanti per effetto dell'aria che spinge in avanti il sangue. Suggerivano di aspettare, ma insomma in realtà è un atteggiamento che può essere accettabile, anche quello di tornare dentro e vedere. Quindi credo che entrambe le scelte possano essere plausibili, però è vero che comunque andare a vedere cosa succede e prendersi cura del problema può dare più sicurezza, specialmente se si è a livello intraoperatorio. Benissimo, quindi prima di vedere altri esempi, I think that so far in summary we could all agree that it depends on the whole list of variables: diagnosis, IOP, low or high, suspect of retinal detachment, and blood in contact with the cornea, and as you said, the age and the status of the other eye, because if the other eye is blind, we don't want to let the patient wait too much. Okay? Silvia, if you want to come and present your talk. Abbiamo parlato adesso di come fare il management di queste situazioni. Adesso invece la dottoressa Bopp ci fa una presentazione su come potrebbero, secondo lei, essere evitate in casi di gestione di retinopatia diabetica. Please.
So thank you. And I'm very happy to be here and share my experience with you. And here it's about diabetic eyes and who have a recurrent bleeding. And the first question when you are faced with such a situation is the why question. Why is it happen? So to have all the possibilities in your mind and then specifically go each by each, and maybe possibly you can focus on the source of the bleeding and then go to specific therapy. That is a little bit that stands behind, and I've listed up the early and the late hemorrhages after diabetic vitrectomy. In the early are usually from the retinal side, that are reopenings from the areas of ablated neovascular tissue, or from choroidal vessels, which are those ones, for example, which we have seen in the example before, that come from the sclerotomy wound, in particular when this is associated with hypotony or systemic hypertension, maybe at the end of surgery, when the patient is waking up. But we are more interested in the late vitreous bleeding, which either can come from the vitreous base, and it's, when you look to endoscopy findings, there are in pockets a high amount of blood clots that are trapped in the interior vitreous. If you have visualization systems like Barbara has shown us, how meticulous she is does vitrectomy in the vitreous base, there cannot be much left. But in many situations, people do not go that far in the periphery and leave lots of blood peripherally, which slowly later on resolves and leads goes to the vitreous cavity. Next are retinal neovascularizations, either missed ones or those who newly develop after vitrectomy, and something which is not so rare and which is quite rarely are those anterior hyaloidal fibrovascular neovascularizations. And last not least, choroidal neovascularization at the entry site where you previously have been. And I would like to give you a few examples to illustrate this. This is the first case, patient typical case with a vitreous hemorrhage who had vitrectomy. You can see at the right, it was quite uneventful, but 1 year later, she developed heavy rebleeding, even more than before, and as this did not clear within 2 months, she had revision surgery, and the fundus drawing shows you two sides, here, and I will go through the video. Is it with a click? No. One click. Okay. Is there a bar? Okay. So this is the case, and although there's not so much quality, so under the biome you don't see so very much after having removed and washed out the blood. We look in the periphery, there's also quite a lot of peripheral vitreous still present. And then I usually use ICG. I'm still a fan of ICG because it can give you a better contrast to the vascular structures. And this is under the contact lens. I check the optic nerve head, and there is another place here. We cannot see it because the light is still on here. There is a tiny neovascularization here at one of the venous face. You can see like a cauliflower. This is one part, and I found another part, so this was removed. And the second one is here at the optic nerve head. It's partially fibrosed, so that I did an LML, but this is not the issue. The issue is that I found two little tiny neovascularizations that are probably the reason for the reproliferation. And another thing is I found the periphery is not fully coagulated. So this was a post-op finding, everything was fine. But let's go back, and this is interesting, to the FAG that was done after the first surgery. And we did an FAG, and you could already see, but we overlooked that here at this point, there is a tiny neovascularization here, and at the optic nerve head here. In the late phase angiogram, they become not so obvious, but they are most likely, and I've seen that in several cases, the origin of late rebleedings. which are persistent, and this is due to the fact that obviously either laser is not enough has been done, or also you have to remove neovascular tissue completely. Sometimes you find in such cases, this is another one, in the periphery, those also tiny little neovascularizations. And these ones, either you laser directly, or maybe you also can cut them, but that sometimes leads to some bleeding. And it's very important to look also for these ones, especially in the interior vitreous space. And another situation is if you look at this eye, here where I have done the circle, this is a severe case with advanced tractional retinal detachment. Some little vessels here occur, and under silicone oil there is a massive growth of these vessels which localize treatment detachment, and that has to be thoroughly revised, because it will definitely, when you remove the silicone oil, lead to bleedings. Those entry site neovascularizations after previous diabetic vitrectomy are not so infrequent, and it is estimated that about 50% of rebleedings come from this source. If you have a sclerotomy, it's a physiologic reaction that you have some uveal, from the uvea coming, fibrovascular proliferation that closes the wound, that later on leads to some involution and contraction, and you have a nice small scar. But especially in the presence of anterior ischemia, this can lead to an exaggerated reaction, and with fibrovascular ingrowth here, which leads to rebleedings. This is an extreme one, and I check always the sclerotomy size if there is a presence of the bleeding. So many things could be done then, endodiathermy, resection, or laser and cryo, and but it is not the issue. I usually remove this tissue. But also the contracted with the vitreous gel triggers the growth of these fibrovascular tissue at the sclerotomy site. And the worst thing is what we call anterior hyaloidal fibrovascular proliferation after vitrectomy. Different to those fibrovascular ingrowths, this comes from the peripheral retinal phases, not from the choroid. And the residual vitreous and the posterior lens surface, this serves as a scaffold for this anterior neovascularization, and later on leads to rubiosis and even to an interior vascularization, especially deep vascularization of the cornea, and most of these eyes are really lost. And in some aggressive diabetics, this can happen. There are some similarities between the fibrovascular ingrowth and the anterior hyaloidal proliferation, and such is that the vitreous base remnants serves as a scaffold, and usually there is a severe ischemic trigger there. But you can see UBM helps usually to differentiate to these two entities, and this picture shows you that the fibrovascular tissue grows in all directions. And this also speaks for the fact that during vitrectomy I have become much more attentive to the periphery with respect to do a very thorough vitrectomy, even in the periphery, and second, that I always do laser up to the aura. And that is since then I haven't seen those situations anymore, and the amount of post-vitrectomy hemorrhage in those patients have gone down to less than 10%. So this image just shows you intraoperative. I don't have that broad view, but as I usually work with bimanually, I always go with a laser, because later on you never go to these areas again in these eyes with an external laser. So I think I stop here and hope will not want that too much time is caught by a presentation, because you do such a lovely cooperation with the discussion.
Thank you. Thank you.
Barbara,
Thanasis, sì,
solo un commento.
lasciami chiedere, Thanasis, do you want to present your...
Yeah, okay, but you
Come on.
have it uploaded already because I have it on my...
I think it's this one,
Okay.
right?
Yeah.
Sì, Mario, dimmi.
Solo un commento. Altra emorragia di cui non abbiamo parlato è dell'emorragia supracoroideale. Abbiamo pubblicato un retrospettivo multicentrico lo scorso anno su American Journal e su 4.000 casi multicentrici lo 0.8% sviluppava un'emorragia supracoroideale dopo vitrectomia. Abbiamo analizzato... Sì. Nello 0.8% avevano un'emorragia supracoroidale localizzata o diffusa, e questa emorragia rispetto ai fattori di rischio analizzati non era correlata né con l'INR né con antiaggreganti o anticoagulanti, era correlato solo con due elementi. Odds ratio al 4 significa, cioè 4 volte incidenza maggiore per una PRP intraoperatoria eseguita appunto nell'intervento che l'aveva preceduta, quindi una coagulazione molto importante. Altro fattore di rischio, l'odds ratio al 24 se il paziente nell'immediato postoperatorio aveva vomitato, quindi tanto che uno dei consigli era quello di dare antiemetici in pazienti a rischio, perché il vomito, quindi l'aumento della pressione toracica a glottide chiusa, può aumentare la pressione venosa a tal punto da indurre in un vitrectomizzato nel primo postoperatorio un'emorragia supracoroideale. Odds ratio a 24 è un'incidenza da paziente.
Just a short comment of what I do, because this is the EVRS study, what everybody is doing. And Brescia is a beautiful city if you have time to go and see it, but Sylvia doesn't like that. So what about the pre-vitrectomy? What to take care before having hemorrhage? How to do things? What about anti-VEGF? You know, everybody, that it's... what about blood pressure control of the patient? So if you have a hypertensive patient and you go to surgery, you might have a risk. During vitrectomy, a few steps. Well, what about thorough hemostasis? Because you have to remember that working under pressure in a vitrectomy, you can have a hemostasis because of the high pressure you're using to solve that thing. And then intraocular pressure control means that you can stop the hemorrhage by your own way of doing it. For the Constellation, for example, there's a double foot pedal that you have on 40 or 25 and 40. So when you have a small hemorrhage, you immediately have to raise the pressure by pressing the foot pedal, go to 60 or something like that to stop the hemorrhage, wait for a few minutes, and then clear it out. Don't wait for the hemorrhage to become a clot, and then it's difficult to remove it. So washing out these clots with an extrusion system, because things now have extrusion system that can help you remove the clots. Don't stop by that. And the other thing is the pressure control I told you before, and laser vascular pressure to the periphery, as Sylvia showed beautifully. It's very important for bimanual surgery in diabetics that you have to do laser to the far periphery, even using scleral pressure. At the end, clots extrusion, the same thing while we're talking. Don't leave the patient with clots on the surface of the eye, because you're afraid that if you remove the clots, it's going to rebleed. No, you have to remove that. And the gradual drop of the IOP. People think that when they have a 30 or 40 millimeters of mercury in the eye, and you have a safe eye and clear eye, that if you remove the trocars, then you're going to have the same pressure. So try to reduce the pressure of the eye before you remove the trocars. Make it 15, make it 10, to see if this bleeding restarts, and then treat this bleeding. These are tricks and tips that I'm using. Never go at the end of a good surgery removing the trocars and leave the eye, because you're not going to have the same pressure. Hypotony is one of the worst enemy we have, especially with trocar surgery. So silicone oil that I'm using, it's only 5,700 CTS through 27 gauge. We have, yeah, only 27 gauge. We're the first doing it, but we can do it. So in proliferative diabetic traction detachment, one eye, usually people are one eye patients or the other eye is not looking very well. They have poor vision. So the history of a post-vitrectomy hemorrhage are people that they have multiple hemorrhages or multiple surgery and they still go back to hemorrhage. Then I'm using silicone oil for these cases, for avoiding the post-op hemorrhage, because they need to see immediately, they need to see the next day, they don't want to stay with air or gas for 40 days or 30 days in their eye. And the other thing, you stop the bleeding because you control the hypotony much better with silicone oil because you can feel the eye. And you have a test for that. I'm not suturing the eye at the end of a silicone oil injection. If you over-pressurize the eye, silicone oil is going to get out of the sclerotomy. So if the silicone doesn't go out of the sclerotomy and you leave a small bubble of air at the end, just to remember that, then you don't have a hypotony. And then people say, as you told me before, Barbara, how to do with the removal of post-silicone blood. Because when you're exchanging fluids, there is a hypotonic phase exchanging fluid. And then you got a little bit rebleeding. What about injecting silicone oil and then you have rebleeding? You fill the injection, you wait for the clot, and then you go with an extrusion. I had a video for that. I don't know if we can show it, about diabetic traction and all this stuff, how you can remove the clot. Remove the clot behind the silicone. You can do that now. You couldn't do it before because you don't have the high extrusion that you all have now. Remove the clot and refill the silicone oil, and this is a way to see, and that's it. Yes, if you can. Yeah. So you see a small short video of a diabetic with one eye patient, and actually he's one of our doctors of our hospital, diabetic, and we need to do bimanual surgery for two reasons. The one is we need to detect every little tiny traction that they have, every little point, of anchor point they have, and cut towards the membrane and not cutting towards the retina. So with this bimanual illuminated, and then you have on the side, you can see the pressure, the cutting and everything. It's 5,000 cuts per minute. And then you see an injection, 5,000 centistokes of silicone oil at the end of surgery. That was perfectly all right. We didn't need to do silicone oil. In every case, you would live with fluid. But we thought that this is going to give us time for the patient to see, and if something goes wrong, we can fix it. So, fixing the silicone oil, we see that there is a rebleeding at the center of the eye. And you see how fast it is. Now we go with an extrusion, we change to extrusion, we go behind the silicone oil and we use an extrusion to remove the clot. And we don't suture the eye. So with this way, we're avoiding people and we let them see immediately. And in case we have some rebleeding or in case we have some other troubles that go detachment or whatever, we buy time with silicone oil. We buy time, which is very essential. You saw there is no break, there is no problem, nothing in the eye, because it's very easy to remove it after 2 or 3 months, especially if you don't need it, it's easy to remove it. But if you don't need it, you need it for diabetic patients with poor vision in the other eye, because you let them see immediately and they're very happy about it. You control hypotony, and the third thing, you buy time to do some more laser or to do something else in between. But if you have just gas or air or fluid, then they don't give you time. You have to intervene again.
Come in tante cose nella... Sì, un applauso a tutti. Come in tante cose nella chirurgia retinica vedete che ci sono i diversi orientamenti. C'è chi fa la vitrectomia rispetto il buccal nei distacchi di retina, c'è chi aspetta a reintervenire mentre c'è chi interviene subito quando ci sono le complicanze, c'è chi usa il silicone più o meno, e tutti avranno da portarvi ugual quantità di pro e di contro. Tante volte le alternative sono accettabili perché dipendono anche da come le gestisce il chirurgo che le propone, quindi non è detto che siano del tutto sbagliate da un lato o dall'altro. Ogni tecnica va conosciuta e la bravura del chirurgo sta anche nel cercare di applicare una tecnica quando serve. Devo chiudere allora la sessione sul bleeding, è stata molto bella.